this is an individual with a learning disability, and when they ring up, they need to have, they always see Dr. So-and-so, and although we have a system that, you book and you have to ring at 8 o'clock or whatever it is, that actually this is somebody that, because they have a learning disability, we make a reasonable adjustment so that they know. Because actually, if the individual doesn't get as far as the clinician, they've fallen at the first hurdle. So it's the sort of whole team approach, really.
Hello and welcome to GPs Talk Cancer, brought to you by Gateway C. I'm Dr. Rebecca Leon and I'm joined by Dr. Sarah Taylor. We're both practicing GPs and GP leads for Gateway C. And in this podcast, we'll be sharing our clinical experiences, reflections and practical insights to support earlier and more confident cancer diagnosis in primary care. Before we start, a quick reminder. Although anyone may find this podcast interesting, it is designed for primary care health professionals. All patient cases are based on real clinical experiences, but are fully anonymised with no identifiable information. Gateway C is a free early cancer diagnosis resource funded by the NHS and based at the Christie NHS Foundation Trust. So we're going to be sitting down today and chatting with Julian Hallett from the Down Syndrome Association. Julian is a service development manager at the Down Syndrome Association and also sits on the advisory board on the LEADER programme. Julian, welcome.
Thank you. Good to be here.
Have you come farther this afternoon?
From Herefordshire.
Okay.
So, cross country. It's a
wet?
big city. Well, not probably as wet as Manchester, but...
Well, I don't think so, because if you look at all the flood warnings across the country at the moment, we're quite spared.
Right. Tewkesbury, which is nearby, that's underwater.
Is it?
Pretty much, yeah.
Gosh.
So...
We're always a bit rainy here, but
we can absorb it. We're used to it.
we are. Always a little bit rainy. Okay, so today is a fascinating topic. And when we met a few weeks ago, this was a particular podcast I was really looking forward to. We're going to be talking about your experience and your role. And you work with the Down Syndrome Association. But I think a lot of this will be about other people with learning disabilities.
Absolutely.
So a lot of what we're going to talk about today, I hope that we can put into to patients that we see.
Yeah. What's the evidence about cancer diagnoses in people with learning disability?
I had a look at the most recent LEADER report, and I think it showed that cancer was the third most common cause of death amongst people with a learning disability. So probably similar to the general population, I should think. So obviously the key message is that people who have a learning disability are just as likely to experience a cancer diagnosis or need cancer treatment as any other member of the community. What it did show, I think, was that of those people, sadly, who died from cancer, a very high proportion of those were avoidable deaths. So, question would be, had they perhaps had an earlier diagnosis or participated in the screening programme, it might have picked up a cancer which then could have had a much better outcome. And I think, they obviously focus on certain case studies, and there are examples perhaps of individuals even presenting, at A&E with a very, life-threatening diagnosis or set of symptoms that actually then indicated a cancer that had obviously progressed very significantly, and sadly then there was very little that could be done to even treat the individual. It was just a case of sort of managing symptoms.
So there are a couple of reasons that, as I think about that, there must be probably a few factors, but presumably some of it is recognition of symptoms, and presumably some of it is conveying the concern about those symptoms and explaining those symptoms and healthcare professionals picking up on them. Is that right?
Yes. Obviously the particular thing to be mindful of would be diagnostic overshadowing. So somebody presents, lots of people with Down syndrome, for example, have issues with their bowel. They might experience regular bouts of constipation. So that's quite a usual chronic condition that can be managed. But obviously constipation can be indication of something much more serious that might mean, a very different type of intervention. So I suppose it's about treating each new symptom as you would probably with any other patient, is doing that sort of detective work. What am I actually seeing here? not just thinking, oh, this is somebody who, might be having a condition that's being managed. It's thinking, could this be, the beginning of something new that, particularly if it might be the onset of a cancer that would require some sort of, quite speedy referral or intervention. And then some people with a learning disability obviously will have greater difficulty in explaining a symptom. Lots of people, might come in, or, the worried well, who could tell you in great detail about a particular change in their health that they want to talk about. Somebody with a learning disability might not recognise the significance of something, know to tell an individual that actually this is something that could be quite worrying. And some people with a learning disability obviously have very limited or even no verbal communication. So it might be that you'd be looking at family members or support staff who know that individual very well to look at other sort of subtle changes in the individual, because the person themselves might not be able to tell you all that themselves.
Something you mentioned a bit earlier was about screening. You were talking about why potentially of that statistic that you used, that the third most common cause of death in the learning disability community was cancer. But of those, that they were presenting later and potentially an earlier diagnosis, and screening was one of the reasons. So screening uptake, I understand, is a lot lower. Why could this be?
I suppose obviously screening, it's an elective process. People choose to have screenings, not compulsory, recommended, you know. So I think it would be finding out, if somebody hasn't actively taken up the offer of screening, is that an active decision? Have they assimilated all the information and decided that they don't want to have screening? Or is it, have they had a letter that they didn't read or they didn't understand or they couldn't read? Did they not understand the benefits of the screening programme? So, is it an active, informed decision to say, no, I don't want to participate? Or, is a non-attendance, interpreted as a declining screening when actually the individual might have opted to take up that offer if it had been explained properly and the benefits of screening?
Do you know whether the bowel cancer screening letters are... Because it always makes me laugh when you see a letter that says, if you struggle with your sight, please ask for this in Braille. And I'm thinking, well, how can you read that if you can't read? But but do they bowel screening letters for people with learning disability? And if you're talking about a learning disability, Downs is will be recorded on everybody's notes, won't it? So that's it. Do they get a different letter? Do you know, or do they get the same one as everybody else, and we have to think about it separately?
I mean, reasonable adjustments in terms of easy read is not done particularly well across the NHS. There is an obligation for health settings to make information available in different formats. As you say, if you can't read the letter initially, to know that you could request it in a different format, that sort of is a bit of a non-starter. I'm hoping that, there's a new or relatively new initiative, the Reasonable Adjustment Digital Flag, which is coming in across all of the NHS medical records, which should flag if an individual has a learning disability. And amongst that flag then would be what the reasonable adjustments might be. So easy read isn't really, it won't be accessible for everybody. So it's not just ticking a box and saying, well, I've given somebody an easy read leaflet. Most people with a learning disability, even with an easy read, would require somebody to go through it with them. So it's a helpful aid memoir, but it's not a panacea to say, well, that individual now has got accessible information. Some people might require, there's some really good NHS animation, so it might be watching a short film about something, or even a GP, taking somebody, making a short recording, just a voice note on somebody's phone, just giving them the verbal information that then when they've got out of the surgery, they could listen to again, or they could play back to a family member so that the family member's got the information as well. You don't need very sophisticated, interpretation in order to do that. Most people would have perhaps a smartphone, and that can be a way of sort of making something that might otherwise not be accessible.
I've written down the word opportunistic health because in general practice, I'm thinking about patients who I've seen who will come in with their support worker, their parent, and I've spent years and I've got on well with them and I know them and I hope that the patient trusts me and I can see that they've not come for their breast screening, cervical screening, bowel screening. And it's an opportunity for us and a privilege, I think, when we work as a GP to actually say, I've noticed that you haven't gone for your mammogram. Can I ask why? And it can be, we've not received a letter, we didn't know. But actually use that opportunity and an individualised approach on how we can explain about that particular screening to them. I like that idea about doing a bit of a voice note. Really like that. And that was something that I can already think about who I'm going to use it for. But we have to adapt what we've got because that letter in the post is archaic for everybody. I hate getting letters in the post because they're often brown envelopes, which scares me about tax bills. But we need to be thinking of a way that we can engage better.
Yes, absolutely. And, as NHS moves more towards digital, there are significant concerns, I think, for people with a learning disability who will be excluded, possibly. Some people with a learning disability, that might suit them very well. A text message, or they might use the app, and they would manage that very well, and a reminder about something. But there'll be other people who won't be able to access that information that way. So it's having an alternative and saying, well, you don't have to only access this digitally. You can still ring up and talk to somebody, or we'll still send you a letter. Lots of people like to have a letter that they can put on the back of the fridge, and that's the reminder that they've got an appointment in a week's time. A text message can easily get sort of lost in the system.
Where does the balance come between capacity and best interest? If you've got a symptomatic patient and somebody comes in with a breast lump, then it seems a much easier decision to either, if the patient's got, obviously the ideal is the patient has capacity and you talk to them about a referral, they agree to it. But I think you can probably come with the patient or with a relative carer, come to a best interest decision if you've got a strong clinical concern about a symptomatic cancer. But it's a more difficult decision, I would say, with screening.
Yes, and ultimately along the lines of mental capacity, individuals are allowed to make decisions that might be considered unwise. It's not about saying you must do this. If the individual is expressing a very significant choice, then that must be respected. And if an individual has capacity, they're perfectly enabled to do that. I suppose it's just sense checking that do you know all the benefits of screening? Have you had time to think about this? Maybe we can, not that you'd continually return to a decision that where a preference has been expressed, but it might be a case of, well, as you said, next time we have an annual health check meeting, we can just revisit that and return to it, and maybe the individual's had an opportunity to think about it a bit more, or talk to family or friends about it, and maybe take a different view.
So I think it's a good time to talk about case 1, Julian, because I think it talks a lot about and goes into a little bit more detail. Because I think as part of your role, you talked about, when we talked, that there is a hotline that you actually...
Helpline, yes, we take calls on everything, yes.
Not a hotline, a helpline.
A helpline. It is a hotline,
It's a hotline, a helpline.
Phone rings red,
Yeah, exactly. It's going hot. I think it would be a good time to talk about a case that was picked up on the helpline. Are you able just to tell us a little bit about it?
Yes, I mean, we quite regularly get calls about cancer screening. So people have had their letter, or, family members received a letter on behalf of somebody that they support, and they're asking for greater information. So this was a lady who had Down syndrome who was within the sort of age range where she would have been invited for a mammogram, and had gone and it had been an unsuccessful first visit. So the radiographer hadn't been able to continue the procedure. There were just basic things like the setup of the equipment. People with Down syndrome are quite often quite short in stature, and she wasn't able to sort of position herself in a particular way, and she had to turn in a particular way that there'd been very little preparation for her. So I think when she went, she didn't quite understand what was going to be asked of her, and basically the procedure was abandoned, and so she didn't actually then end up having the mammogram, partly I think because there hadn't been any preparation for her, and I don't think probably the clinicians even were aware of the fact that the person they were about to see even had a learning disability. Otherwise, they would have probably made a bit more preparation or set the room up slightly differently, or you know, maybe given her a longer appointment. There could have been various reasonable adjustments that could have been made that would have meant that could have probably progressed, you know, satisfactorily.
So what did she end up having? Were you able to facilitate a mammogram in this patient? Or
I think she had a good support from a sister who was particularly keen, obviously, for her sister to be able to have the mammogram. So we suggested that the breast screening team maybe had some advice from the Community Learning Disability Service. So there are specialist nurses, Community Learning Disability team, that would be able to provide some extra support, both to the setting, so give them a little bit of a sort of briefing, really, but also dig out things like easy read materials, look at what accessible information there was so that the lady could be prepared for what was about to happen. And I think they even did a bit of filming in the room that she was going to go in, so that she could see the equipment, be explained about what was going to happen. And they did a little bit of a social story. I don't know whether that's something you're familiar with, but it's sort of outlining to an individual exactly what's going to happen, where it's going to happen, who's going to be involved. You know, if you know the name of the radiographer and if you've got a picture of him or her, that can be very helpful. And what would be the best outcome? Well, the best outcome is that you go and you have your mammogram and it's all done, you know, and then we go for a cup of coffee after. And so that's what they did, prepared her and had something nice to look forward to when the procedure was going to end. And then she was able to do that very well. So an initial sort of false start, but actually then turned into a positive and a slightly different approach.
Do you think some of these things are driven by the patients wanting it done or family members wanting it done for them? I can understand if a sister had, maybe they had a family history.
I think that was the issue, that there had been along the sort of female line in the family, mother, aunts, sisters and things that had issues with breast cancer. They felt it was particularly relevant that she had that. And obviously, you know, not everybody has family around them to do that reinforcing or to just to check out
to be
with
an
somebody.
advocate for
to be an advocate, exactly.
I want to ask you, because you mentioned about the learning disability nurse at the hospital, it helped. And one thing I'm going to take away is for patients who are needing that little bit of input advice to actually go through this social, what did you call it?
Social story.
Social story. That's what I was going to say. No, my question is, for practice nurses, for our in-house
primary
nurses, primary care, community nurses, what can they do to make the whole experience better? What do you think we could put in to our practices or for people who are going out into the community for better engagement?
I mean, you've got the Oliver McGowan learning disability training, which you know, and the different tiers. Obviously, the beginning of that is very sort of broad brush messages, but the more detailed, you know, tier 2, tier 3 training goes into much more detail about reasonable adjustments.
Great.
I suppose it's not having a one size fits all. You know, sometimes it is as basic as you know, a very hard work receptionist not understanding that actually this is an individual with a learning disability, and when they ring up, they need to have, you know, they always see Dr. So-and-so. And although we have a system that, you know, you book and you have to ring at 8 o'clock or whatever it is, that actually this is somebody that, because they have a learning disability, we make a reasonable adjustment so that they know. Because actually, if the individual doesn't get as far as the clinician, they've fallen at the first hurdle. So it's the sort of whole team approach, really. And then I suppose realising that, I mean, the more you can get to know the individual patient, the better, because one person's reasonable adjustment may be very different to somebody else. So it's not thinking a person with a learning disability will require this reasonable adjustment. It's finding out from the individual what actually would be helpful. And some of these things are very easy to facilitate.
And how often do you think you need to, because obviously when you're looking at children, you take a lot of store by the parents' history. Presumably you need to do that to some extent with people with learning disabilities. So how would you suggest that we try to make sure we don't miss symptoms and signs in people with learning disabilities who may not be as good at giving us histories?
I mean, I suppose from a clinician's point of view, I suppose you ideally want to hear directly from the patient themselves, because if it's gone through the prism of somebody else, you might get a different answer.
Ideally, yes.
But particularly for individuals with a learning disability, and and young people, as they're moving into adulthood, they then become more capable and able of taking charge of their own health. But it's always, I think, listening to family carers, and it is usually a parent or it could be a sibling, and taking their concerns seriously, because they do know the individual better than anybody. And so if they're saying, somebody's demeanour has changed, it might be a very, very subtle change, particularly in somebody maybe who has very limited verbal communication. It might be their eating patterns, it might be their sleeping patterns, it might be their interest in particular things has changed over a period of time. And that would be indicating to a parent that something's not quite right. And it's just taking that seriously, really, because that gut feeling, I think, that parents have if something isn't right often is right. It is right that they might not be able to, well, they won't, they're looking to you to then find out maybe, what's actually causing the pain or the distress or the change in the individual.
Do you think there's a concern amongst health professionals that they don't want to put people through, we do lots of blood tests, but they don't want to put people through tests that they might find uncomfortable, or do you think that's an issue as well?
We get a huge number of calls around blood taking,
right?
And there's lots of things that obviously that's the first or one of the first ports of call, isn't it? Let's do some blood tests and see what might be happening, because that can tell you a lot about somebody's sort of physiology. And there are lots of strategies that can be used to help somebody who is not very good at giving blood. So it's not seeing that as a dead end, because that closes off so much to you.
Absolutely. That's
people with Down syndrome, for example, they need to have very regular checks on things like thyroid function. So it's important that they get to a state where they are comfortable in having blood taken. Obviously, nobody wants to expose anybody to an invasive procedure if it's entirely, in any way avoidable. But I suppose it's not thinking that the individual, because it's more difficult, it's not worth exploring, or because perhaps a more invasive treatment let's say if somebody is diagnosed with cancer, there are various options. We could watch and wait, we could, surgery, we could do chemotherapy, there's all sorts of different things that might be an appropriate intervention. And it's not thinking just because somebody has a learning disability, they won't be able to comply with post-operative care or something, so that we're not going to explore what might have the best outcome. And sometimes we talk to families where they've done their own research and looked at different options if somebody has been diagnosed with a cancer, and it's not closing one particular treatment regime off because the individual has a learning disability, because that's obviously they're being discriminated against because of the basis of them having a learning disability.
Yeah, absolutely.
Do you also agree about not being presumptive? Is that the right word?
Yeah, I think so.
Yeah. So we use the example for cervical screening that if somebody may or may not be sexually active, we shouldn't presume that they're not. And I've had a lot of people over the years who, for one reason or another, and there's other myths and other reasons why people don't have cervical screening, is that with people with learning disabilities are not sexually active. We can't be making that kind of presumption.
Absolutely not.
Yes.
No, certainly not making an assumption. Or even, again, you were talking about a family member. My parents didn't know about my, private life when I was becoming an adult, and lots of people have,
private lives.
Private lives and dignity and respect. And sometimes, you might get a different answer actually if you were talking to the individual on a one-to-one basis and they didn't have a family member, perhaps. So it's absolutely not making that assumption. And of course, it's an indicator of a risk for certain types of cancer, but no risk or low risk doesn't mean no risk. So it doesn't necessarily mean that somebody shouldn't participate in that programme, because they may still show something that could require intervention.
Yeah. Case 2 was something that I think was another call-in, Julian, and this was somebody who had gone to the GP asking if there were any resources to help explain testicular cancer self-checks for a male patient who had Down syndrome. And you discussed about where to signpost patients. Can you tell us a little bit more about signposting?
Yeah, I mean, there are lots of, all the major cancer charities will nearly always have easy read material. Yeah. So, if in doubt, look at there's good resources within the voluntary sector. I suppose that's the advice really, and something like that can be done. I mean, obviously, it's difficult because self-examination is something that obviously the whole point is that the individual themselves takes responsibility for doing that, and somebody could do that quite successfully if they were given resources to explain, how to do that. And it's there, as I said, there are some really good resources available. The Down Syndrome Association has lots of information on our website. There's Easy Read. Some of the NHS, if you go on NHS Digital, they will have Easy Read resources, and there's a particular strand of books called Books Beyond Words, and they're picture books, and they cover a whole range of different topics, lots of them health focused.
That's really good.
And they can be a very good resource.
Looking after my balls.
Yeah,
that's
exactly.
The one. Yeah, that's Books Beyond Words. It's really
that's really
we did
helpful.
some work a little while ago with NHS England around constipation and sort of linking it to what that might be an indicator for. So we spent weeks and weeks and weeks talking about poo, and I know more about the Bristol stool chart than I've ever thought I would know. And that was making an accessible resource. So there was easy read materials and actually a little animation as well that was made, all about talking about poo.
Yeah, and videos and things I think are quite useful as well, aren't they? Yeah. One of our nurses did a video of what happens when people go to a smear test actually at our practice. Right. That they were sending out to all patients who hadn't come in after an initial thing, just saying, hello, I'm so-and-so, I'm the practice nurse, this is what we do. And I think that sort of just video and spoken thing can be easier for people. And it also means that when they come in, they can, as you said before, they can see, actually, that's the nurse who was on the video. So I feel like I already know
You're
her.
relaxed, You go in and it's, because it can be, lots of frightening experience if you don't know if you're not prepared for what might happen.
And it's important that first experience is something that doesn't frighten them come back again. And even just by making the room warm and not the speculum to run it under warm water, these kind of things can just make people a little bit more relaxed. So they don't say, well, I'm not going there again. Mm-hmm. Absolutely horrific. Yeah. It's not pleasant having a smear test, but it's something that is important and that they come back for.
How often do you, I just sort of think again about best interests in patients who don't have capacity. Well, how would you suggest we approach non-verbal patients who have got a symptom that we're concerned about?
I think listen to those who know the individual well, and if that's it very often is a family member, so it could be a parent, it could be a sibling, it could be a support worker. People may be living in supported living that have key workers that know the individual very well. So take because they will know the individual very well, and they'll know the way that the person perhaps is communicating that they're in distress or discomfort, or that their health has changed. And then I suppose it's about having, because I'm sure so much of medicine is playing detective, and as you said, somebody presents being tired or lethargic, and that could be one of 150 different causes, but it might be something that's quite serious, that needs some sort of intervention. Maybe having a lower level of a threshold for referral. And
where do you start? So if the patient is non-verbal and you're struggling to work out whether the patient is consenting to the referral, which can be difficult to do sometimes, can't it? Would you then go to somebody who's got a power of attorney? Can you make a best interest with whoever's in the room?
I mean, lots of people do have an appointee, but obviously you have to have, in order to grant power of attorney, you have to have already had capacity to be able to. So that's very often the case, say somebody with dementia, perhaps that is losing capacity, but often for people with a learning disability, they haven't necessarily gone down that route. And as lots of families encounter this as their young person becomes an adult, because as a parent of a child, you have that decision-making power to a degree. But as the individual then becomes an adult in their own right, even from the sort of teenage years upwards, you should be involving the patient themselves in making those decisions as much as possible. And then by the time the individual is an adult, they have that decision-making power in their own right. Difficulty comes then and it's decision by decision basis. So, people might well be able to make decisions about certain things, but quite big decisions like, say, consenting to surgery, for example, where there are, certain risks. I mean, no process is without a risk, and making that informed decision obviously is quite difficult, and lots of people would perhaps struggle to make those decisions without help. So they may need help from people around them that who've got their best interests at heart, really.
Yeah, so it's just it's a best interests decision.
And an individualised approach.
Yeah, totally, because it'll vary by patient, won't it? And
but it is that transition.
It is that, because
it's difficult.
Yeah.
But I think you're absolutely right. They've almost got to have the capacity at some point
to get the power of attorney, so they're not going to have power of attorney.
But I suppose, thinking about it from a Down syndrome point of view, they've got an increased risk of dementia. So therefore, there might be a time in their life that they do have
they do lose
capacity, and then that they can lose capacity later on. So that's an example.
Yes, and some families have explored that process and have done that, but then lots of people, I think the difficulty is that it only becomes an issue when you need to do it, and then it's like it's
that's for everybody, isn't it? Often, isn't it?
Done this earlier.
Yeah.
So I think we should do some key clinical points, one each.
Okay.
Sarah, you start.
So I'm going to say that for people with learning disabilities, decisions need to be individualised.
Julian?
I'd say find out about the NHS Reasonable Adjustment Digital Flag, and that's a really helpful way of identifying patients that might need a reasonable adjustment, and also finding out what those reasonable adjustments are, because they'll differ from individual to individual.
I'm going to talk about Easy Read, and also a new resource, Books Beyond Words, which I think will be something that we can let patients know, and the link will actually hopefully be with our show notes, an example. So primary care can use this as an example. I think that will be something to signpost for our patients. Mm-hmm. Okay. And final thing.
Oh, gosh.
Word of the podcast. Julian, have you got a word?
Oh, gosh. Be detective. Always think, don't be wary of, and there's lots of words, isn't it? It's about detective, not assuming that something might not require further investigation.
Sarah?
Well, I was going to go for awareness, which is a little bit similar, but I think it's just an awareness that things might present slightly differently and you need to think about it. A bit like we said with kids.
And I'm going to go assumptions.
Yeah.
Don't have any.
Yeah, perfect.
Well, that was fantastic, Julian, and thank you so much for joining us. And thank you for listening to GPs Talk Cancer from Gateway C. You can access our CPD accredited modules anytime via our website, and all reference studies and guidelines for this episode are linked in the show notes. A big thank you to Julian and to our producers from Gateway C and Listening Dog Media. If you haven't already, please follow the podcast so new episodes drop straight into your feed. And if you think a colleague would find this episode helpful, we'd really appreciate you sharing it. It helps us reach more primary care health professionals. Thanks for joining us, and we'll be back again soon. Bye-bye for now.